Hi, this is Mel from the Pathology series, and I'm going to talk about anemias, in particular about macrocytic and microcytic anemias. Anemia is defined as a decrease in quantity of RBCs, which is represented by a reduction in hematocrit, HB count, or RBC count. The HB is below 13.5 grams per deciliter in men and below 12.5 grams per deciliter in women. It presents with symptoms of hypoxia, which are weakness, fatigue, dyspnea, headache, lightheadedness, pale skin and conjunctiva, and angina and pre-existing coronary artery disease. Microcytic anemia is defined as an anemia with an MCV below 80 micrometers to the power of 3. The etiology is a decreased production of HB. This leads to an extra division of RBC progenitor cells into even smaller mature cells to maintain the HB concentration. HB consists of iron and protoporphyrin. A decrease in one of those leads to an decreased HB production. It can be caused by iron deficiency, chronic diseases, sideroblastic anemia, and thalassemia. Iron deficiency anemia is the most common type of anemia. It is the most common nutritional deficiency, and 1/3 of the world's population is affected by it. A decrease in iron leads to a decrease of heme and decreased HB production. Iron is derived from heme, which is derived from meat, or iron is derived from vegetable sources. Enterocytes can transport iron across the cell membrane into blood via ferroportin. It is transported in blood by transferrin to the liver and bone marrow macrophages. Intracellular iron is bound to ferritin, otherwise it would form free radicals and damage the tissue. Iron deficiency is usually caused by dietary lack or blood loss. Anemia of chronic diseases is caused by chronic inflammation or cancer. It is the most common type in hospitalized patients and leads to a production of acute phase reactants from the liver like hepcidin. Hepcidin sequesters iron in storage sites by limiting iron transfer from macrophages to erythroid precursors and suppressing erythropoietin to prevent bacterial consumption of iron. A decrease of iron leads to a decrease of heme and decrease of HB. Sideroblastic anemia is caused by defective protoporphyrin synthesis. A decrease of protoporphyrin leads to a decreased formation of heme and HB. The final reaction of protoporphyrin synthesis takes place in the mitochondria. Iron is transported to erythroid precursors and enters the mitochondria. It remains trapped due to the lack of protoporphyrin. The iron-laden mitochondria form a ring around the nucleus, and these cells are called ringed sideroblasts. Sideroblastic anemia can be congenital or acquired. When it's congenital, it's caused by a defect in the ALAS enzyme. When it's acquired, it's usually due to alcoholism, lead poisoning, and vitamin B6 deficiency. Thalassemia is caused by a decreased synthesis of globin chains. A decrease of globin leads to a decrease of HB and microcytic anemia. The mutation protects carriers from malaria. It can be divided into alpha and beta thalassemia. Alpha thalassemia is caused by gene deletion. Normally, there are 4 alpha genes. So when one gene is deleted, this leads to an asymptomatic course. When 2 genes are deleted, this leads to mild anemia with increase of RBCs. When 3 genes are deleted, this leads to a severe form of disease, where beta chains form tetrameres and destroy RBCs. When 4 genes are deleted, this is lethal in utero and leads to hydrops fetalis of a fetus. Beta thalassemia is caused by point mutations which are seen in people of African or Mediterranean descent. Normally, there are 2 beta genes present on chromosome 11. When one of them is defective, this leads to beta thalassemia minor, which has an asymptomatic course with an increase of RBCs. On a blood smear, you can see macrocytic hypochromic RBCs, and there's a slightly decreased HbA with an increase of HbA2 and HbF. When both copies are defective, this leads to beta thalassemia major, which is the most severe form of the disease. It leads to severe anemia a few months after birth. Characteristic for beta thalassemias is hemolysis due to alpha tetrameres. There is erythroid hyperplasia, which leads to hematopoiesis in bones, and hepatosplenomegaly. These people need chronic transfusions, which increase the risk of secondary hemochromatosis. Macrocytic anemia is characterized as an anemia with an MCV above 100 micrometers to the power of 3. It is most commonly caused by folate or vitamin B12 deficiency. Both of them are required for synthesis of DNA and RBC precursors. Lack of one impairs DNA synthesis. The division of precursors is impaired, which leads to larger cells and then megaloblastic anemia. The impaired division affects also granulocytic precursors, which leads to hypersegmented neutrophils. It is also seen in epithelial cells of the intestine. Other causes can be alcoholism, liver disease, and certain drugs. Folate is obtained from a diet, from green vegetables and fruits. It is absorbed in the intestine, in particular from the jejunum. Folate deficiency is caused by poor diet, especially in alcoholics and elderly people, due to increased demand in pregnancy, cancer, and hemolytic anemia, or due to folate antagonistic drugs like methotrexate. Clinical features of folate deficiency are macrocytic RBCs, glossitis, a decrease in folate in serum, and increase of homocysteine. Vitamin B12 is uptaken by the diet by consumption of animal-derived products. Gastric parietal cells produce intrinsic factor. Vitamin B12 binds to intrinsic factor in small intestine, and the complex is absorbed in the ileum. Vitamin B12 deficiency is less common than folate deficiency because it takes years to develop due to large stores in the liver. Causes of vitamin B12 deficiency are pernicious anemia, pancreatic insufficiency, damage in terminal ileum, and an unbalanced vegan diet. Thank you for watching this small summary about microcytic and macrocytic anemias. I hope you found this helpful. See you soon!